Hey guys, welcome back to the Fertility Confidence podcast. I'm so excited you hit play today, and I am going to be walking you through 3 fertility myths today. So I had this idea that we would bust some myths in the fertility world, 3 things that we hear quite often our clients say to us or ask us questions about, or things that our clients are actually hearing out in the fertility community or with their other practitioners or with their fertility clinics. So I picked 3 things that we feel very strongly about over here at Fertility Confidence Method. And hopefully you're listening today because you are having 1, 2, or 3 of these questions kind of roll through your brain, or are situations that are happening in your own fertility journey right now. So let's just dive right in. Myth number 1 is that you won't get pregnant if your AMH is low. And this actually comes up every single week. I find a lot of women actually reach out to work with us because they have low AMH, or they've been told that they have low AMH. And sometimes they're getting a very doom and gloom fertility sentence. Google definitely doesn't paint a really beautiful, awesome picture about low AMH. So we have talked about it on the podcast before, but I wanted to just dispel this myth for you one more time because it is a continuous question that we get asked. First and foremost, there is research to support that AMH does not predict clinical pregnancy outcome. So what I mean by that is that where your AMH actually is in the reference range does not actually equal your success or your lack thereof. So women with a high AMH might not ever get pregnant. Women with a low AMH may get pregnant, no problem. It does not predict clinical pregnancy outcome. A lot of clinics used to and still use AMH to drive any and all decisions about how do we treat and manage this fertility case. AMH is anti-Müllerian hormone. It's actually produced by the primordial follicles, the teeny tiny little follicles in your ovaries that are then being stimulated from the hormones in your pituitary to grow and develop. Eventually one of those, or maybe 2 of them, are going to ovulate. So the theory is that the more AMH you have, the more eggs you have in your ovaries. The less AMH you have, the less eggs you have in your ovaries. What I have found through clinical experience is that's not actually necessarily always the case. And so when I have someone come into my practice with a low AMH, the first thing we always want to do is actually get an antral follicle count. So going in there with ultrasound, sometime between cycle day, like 3 and 10, I would say like 5 and 7 would be perfect, and actually visualize the number of follicles that we're seeing in the ovary. Because yes, sometimes low AMH equals low ovarian reserve, and we absolutely need to make different and quicker decisions on your fertility journey. Maybe IVF is the best option for you, but we truly shouldn't be making that decision until we actually visualize the ovaries. So we want to get in there and actually get an antral follicle count. And like I said, best time to do that, like day 3 to 10, 5 to 7 would be awesome. It's obviously sometimes hard to plan those things, but we definitely want it in that first half of your cycle. You don't want to be getting your AFC done in your luteal phase. You are not going to be able to visualize the appropriate follicle that we're looking for. So we want to do it in the follicular phase. So let's not get super panicked unless we've had that test done, and let's not make any huge fertility treatment decisions until we've had that test done. Because I have had numerous amounts of clients have a low or suboptimal AMH and actually have a really beautiful antral follicle count and no ovarian reserve issues whatsoever. So AMH tells us nothing about quality, and it might not be the most accurate prediction of quantity either. So do not let it be a doom and gloom piece, okay? Because it doesn't drive clinical pregnancy outcome, and it may not even be your best driving, what's a good word? The best, my brain's obviously not going to pull it out, but marker, the best marker for ovarian reserve, okay? So hopefully that helps about AMH. That's myth number 1 that we hear all the time. Myth number 2 is that you completely need to cut out caffeine and alcohol to make a baby. And I don't personally hold that belief based on what we know in the research and based on certain personal circumstances. So there may be clients that we work with that cutting out alcohol and caffeine completely actually make a lot of sense. But as an overarching broad concept for every single couple who is trying to conceive, I don't believe that that's an accurate treatment principle for the wide fertility population. What we know from the research, and when we look at it from an evidence-based perspective, we can see that potentially with more than 150 milligrams, 200 milligrams of caffeine, an increase in miscarriage risk. We also have some research to show there's no change in miscarriage risk with caffeine. So it's a bit of a gray area, but we're not seeing any research, at least I haven't thus far, on caffeine intake, period, impacting your body's ability to conceive. So potentially an increased risk of miscarriage with 150 milligrams of caffeine or higher. So we're looking at like 2 cups of coffee, or I think it's actually 3 cups of coffee. It depends on what kind of coffee you drink, I should actually say, because every coffee, tea, they all have different levels of caffeine. You have to remember that if you are like a coffee and tea drinker, like those obviously add up. So typically we tell people, like, if you are someone who likes to enjoy caffeine, you can absolutely have a cup of coffee in the morning if that serves you. If it is something that is going to bring you anxiety or worry or what ifs, then obviously that is a personal decision where reducing or cutting caffeine might actually make more sense for you. If you are someone who has recurrent pregnancy loss, talking about is caffeine a good option for you is a conversation we would want to have for sure. So that's where I mean where the personable variables are going to come into play, but that's what the research shows us when it comes to caffeine. With alcohol, it's very similar. So we see in couples going through IVF that men or women who are having more than 4 drinks per week are having lower pregnancy outcomes. Now, we don't have any research with alcohol and natural conception and rates. So most of our research is done in IVF, and we kind of just like extrapolate that data over into our non-medicated conception situation. So 4 drinks a week. Does that mean that you should cut out alcohol completely? Again, it's kind of similar to caffeine and very much depends on where you're at in your personal stance and how that's serving your body. For some couples, it will make sense and be more appropriate to cut caffeine completely when we're looking at their overall level of inflammation, their overall level of stress, their body's ability to properly detoxify and things like that. It might actually make more sense to cut it out completely. Or it might be okay for couples to keep a drink or 2 a week, help them to feel more normal, quote unquote, in social settings. And it's not something where if they have 1, they're going to have 7. You know, this is where that personal piece comes into play. Like, can you have just 1 drink and feel satisfied? Does that 1 drink actually serve you? That's going to be a very personal decision. But what we know from the research is we're seeing that decreased pregnancy rates with more than 4 drinks a week. And if we're looking at that, that's only 16 drinks a month. That, 16 sounds like a big number, but I think if we all sat down and said, okay, when I go out with my friends, excuse me, on Saturday night, and you actually look at appropriate servings of alcohol, like how many drinks are you having every weekend? And adding that up and looking at that. And I will also want to just like quickly reiterate, this isn't just for women. This is also a statistic for men as well. And then myth number 3 is also in the male realm, and that's sperm won't be an issue if your partner has made a baby before. And we hear this from a few different angles. We see this in our population of couples who the male partner has kids from a previous relationship. We see it in couples who are dealing with secondary infertility, and we see it in couples who are having miscarriages, where a practitioner will say, well, it's obviously not the sperm, or sometimes the male partner will have the mentality of, well, we're getting pregnant, so it's not my problem, right? Like, I'm doing my job, I'm getting you pregnant, so therefore it can't be sperm. So those are the 3 scenarios that we see quite frequently where men either feel like they don't need a proper assessment, or practitioners feel that the male partner doesn't need a proper assessment. And that is simply not true for a wide variety of cases. First and foremost, if your partner has kids from a previous relationship, I'm assuming it's been a couple years minimum, maybe longer. Maybe we're talking like 5, 6, 7, 8 years. A lot can change in just a couple of years. So just because they have fathered babies before does not mean that their sperm is still good, or they still have good concentration and good motility. Sperm can change so quickly. Age plays a factor. So if we're looking at a partner that had a baby in their early 20s and now they're in their mid 30s with you, like that's a big difference. We need to make sure that a proper assessment is being done. The second piece with secondary infertility is kind of the same look. If it's been a couple of years and you had no issues the first time and you have issues the second time, of course we're going to work up, you as the female portion. But like I said, sperm can change and can change very, very quickly in the matter of a year or two or even less. So we don't want to just completely discount the fact that it's happened before, so it can't be that. And the same goes with miscarriages. Miscarriages aren't just a female issue. They're not just a uterus issue. Sperm quality is 50% of the equation when we're making an embryo. If sperm quality is not great, if the DNA integrity of that sperm is not awesome, that can be a contributory factor to miscarriage. So we do not want to let that piece slide and potentially be missing something really, really huge that we can make an epic impact with when it comes to your fertility journey overall. And it saddens me, especially because I'm actually going to share this story. I don't know if I've shared this on the podcast before, but back when I first started out, I had a client and I didn't see her partner. I asked some questions about him, but I didn't bring him in for a visit. I didn't do an assessment. I just worked with her, and we worked for a year, and we did acupuncture. We did all the things. We did a lot of testing, a lot of gut stuff, and it still wasn't working. Referred her over to a fertility clinic. The fertility clinic did their thing, and through the process, we actually found out that her partner had very, very, very little sperm. Like IVF was their only option. And the reasoning for that was he had actually had a surgery when he was younger. Ever since that moment, I have been very, very diligent at assessing and addressing the male part of fertility, because I felt a significant amount of blame for a long time that I wasted this couple's entire year by not figuring that out, not asking the right questions, and not doing a thorough assessment. And it was a huge moment in my career. And it really drove how I've practiced moving forward, because if I had pulled him in for a visit, if I had asked the right questions, there's a lot of what ifs in this scenario, they could have had their amazing, beautiful twins, a year earlier than they did. And so now it is a big piece of the puzzle for us at the clinic and in Fertility Confidence Method to make sure that we are properly assessing the male partners and we're not potentially missing anything. And that includes our male partners who have had previous children, or if you're having recurrent miscarriage, because that part does not matter in my opinion. It's about the right now. And because sperm quality and quantity can change so quickly with various different risk factors like nutrition and stress and movement and sleep and supplements and medications and weight and blood sugar control, there's so many potential daily environmental impacts. We want to make sure we're getting that properly assessed. So if that is the scenario that you're in, I hope this helps you advocate strongly, either with your partner or with your clinic or your doctor, to actually have that assessment done. So those are the 3 myths. Hopefully that was helpful. If you are listening to this before November 28th of 2022, we are running our Fertility Confidence Bootcamp next week. I am so excited. We already have almost 600 couples joining us. It is going to be our biggest and best event yet. And it is going to be so fun. And I'm hoping to have like finally kicked this cold. You know what? It's so funny. I actually got sick in the middle of boot camp in September. It's kind of what like started this perpetual fall illness scenario that myself and my family have been dealing with. And so I was actually a little bit grateful when I got sick last week. So I was like, you know what? Better now than in the middle of boot camp like last time. So if you are catching this episode before the 28th, come and join us in boot camp. It's 5 days. You get to work with me and my team for free. We're giving away over $400 worth of amazing prizes. We have so many special things planned for you, and you're going to walk away with action items and the next steps for your fertility journey. And you can register for the bootcamp at www.kelseyduncan.com/bootcamp-registration. And if you're catching this after the 28th, I'm so sorry you missed it. There will always be another bootcamp, and you can actually head over to that link and pop on the wait list so that you don't miss it for next time. I will see you guys all in the next episode.